Hi, everybody. Good evening. Can everybody hear me and see me? Okay. So why don't we get started? How many of you out there are working in hospitals right now? Okay. So we've got some of you working out there. Okay, so let's get started. I'm sure that you've read my bio and know something about me, but I always like introducing myself. My name is Alina Gonzalez Mayo, and I'll be going over psych. Psych is split up, so let's all review our schedule. We're here from 6 to 10 tonight, and then I believe from 12 to 3 and 4 to 6 tomorrow. Does everyone understand that change in the schedule? And then I think we meet, I thought it was 4 to 7, but then mine said 4 to 6. So we'll have to verify that. And then we'll meet again, I believe, the first Monday in March, which I think is March. Tomorrow we should start at noon. So I think tomorrow is from 12 to 3. I have to check. Okay? All right, yes, noon Eastern Standard Time. And then we meet again, I believe, the first week of March. All right, so I'm originally from Miami. I went to the University of Miami undergrad, and I went to medical school in Guadalajara. I did my training in psychiatry in New York City at St. Vincent's, and then a fellowship in forensics at NYU. Then I worked for the state of New York for a few years, and now I'm back in Florida working in the VA, the Veterans Administration Hospital. So let me tell you a little bit about psychiatry. If you see my notes, they're really the smallest of all the sets of notes. I think they're very thorough, and I think if you know what I go over, you should do well on the exam. What I've done with the medications is that they're all in the back of the book, so probably the last day of class is when we'll go over all of the psychopharm in detail. I mean, I'll be going over medications as we go over the topics, but I will be going over them in detail at the end in one of the last chapters. Okay, so do any of you have any questions before we start? Let me use the whiteboard for a second because I want to explain something to you. Let me get something to write on. Give me 1 second. Okay. All right. In psychiatry, you know that what we use is what was called the DSM-4, and that's the Diagnostic Statistics Manual, and this is the textbook that we use in order to get the different diagnoses. DSM-4 does not exist anymore, and what we are using is, DSM-5. Now, your exam, DSM-4 came out around the spring, summer of this year. DSM-5 came out in the spring, summer of this year. There have been changes from DSM-4 to DSM-5. I cannot imagine that all of these changes will make it to your exam. I'm assuming that by the end of this year, I'm sure all the questions will be DSM-5 ready. Some names have changed for diagnoses, and we'll be going over these different names. The diagnoses themselves have had minimal changes. All that has been changed significantly from DSM-4, from DSM-5, is the names of the chapters. Your notes are not DSM-5 ready as far as the chapters are concerned. The diagnoses are the same, the treatment is the same. We just need to do a little bit of tweaking in order to make everything DSM-5 ready. But I wouldn't worry about it if I were you. So Does anybody have any questions before we start? All right, let's get started. As I go through each section, I will be telling you what is high yield and what is low yield. Tonight, my goal is to do chapters 1, 2, and 3. So that's where I'll probably end for the night. So this first chapter, let me get something to color, hold on. This first chapter, which deals with the mental status exam, is not a high yield in that they're going to ask you what's a hallucination, what's a delusion. You know they're not going to ask you things like that. But you need to understand the basic concepts because some of the terms that we'll go over here will be used in your questions. So you have to understand what these concepts are in order to answer these questions correctly. So, when we talk about the mental status exam, this is really the main tool that the psychiatrist has in order to get to a diagnosis. If I were a pulmonologist, for example, and the patient is coughing incessantly or has some breathing problems, I could stick a scope in the lungs, I can get a biopsy, I can get an x-ray, I could do all kinds of tests that will give me information about the lungs. I can't do that with the brain. I can take MRIs or CAT scans, but it's not going to tell me whether you have diagnoses, whether you have depression, whether you have schizophrenia, or whether you have panic disorder. So the only thing that we use, and I don't want to use the word only, the most important thing that we use is the mental status exam. And that's where you sit down with the patient, talk to the patient, and figure out what is wrong with that individual. So let's review the different parts of the mental status exam. So one thing that's very important is the description. So here we start to look at the appearance. What does the person look like? Are they clean? Do they have poor grooming? Are they disheveled? Are they unkempt? This in itself is not going to give you a diagnosis, but it could give you a clue for a certain type of diagnosis. For example, when they use the word, let me use the text box for a second. Give me a second. I'm going to write something. I need to write it and then it will appear. When you see the word disheveled, when you see the words unkempt, who are they typically referring? When you see those words in a mental stat? Exactly, you're referring typically to patients who have schizophrenia. These are patients who have thought disorders. So their thinking is impaired. So how they look is also going to be affected, right? Now, when we think of the appearance, when patients are depressed, are they going to take care of themselves? Is she going to make sure that her clothes are ironed, or might she not bathe and wear wrinkly clothes? Right, she probably won't. When you have an elevation in mood, like you probably see in patients who have mania, then you're going to be drawing a lot of attention. Maybe this same woman will now be wearing lots of makeup, lots of jewelry, lots of bright colors. So when she's putting on her makeup, you'll see bright red. Those are her. I'm not a very good artist. So her cheeks, she'll just color them in, and that's what you could see when a patient has mania. When I was in New York on one of the women's unit, there was a woman who was bipolar. And whenever her mania would start, she would get bright red lipstick and color her cheeks in bright red. And then she would paint her lips over the line, like probably older people do. That's a joke, of course. And you would know that that individual, her mood is definitely starting to get elevated. So how they describe the person will be a good clue to what possibly the diagnoses could be. The next thing we're going to look at is what's the patient's behavior. And are they let me go to a whiteboard. So when we look at the behavior, we're looking at various things. Give me a second here. Do they have agitation, right? Or do they have slowness? What kind of disorders could make people restless, anxious, fidgety, moving up and down, and easily excited? Well, we know that patients, when they have mania, they can get agitated, right? That doesn't say mama, that is mania. When patients have anxiety, then we know that, of course, they're moving around. How, describe yourself. You know when you have to take the test and you're sitting in that little room before they let you into the computers? What is it that most of you are doing? And it's not you, it's the people around you. How many of you are doing this with your fingers? How many of you are twirling your hair? How many of you, if your legs are crossed, you're moving your feet constantly, or you're moving your feet up and down sitting in the chair? That's something that all of us do, and you see that in anxiety. You also see a lot of agitation in the patients who have schizophrenia. So there is a type of schizophrenia, and remember, here's good news for you. Are you ready? Do you remember the 5 types of schizophrenia? The paranoid, the catatonic, the disorganized, all that good stuff? Do you remember them? Guess what? They don't exist anymore. So DSM-5 removed all the different types. So you're schizophrenic, period. You don't need to know what type of schizophrenic. When we get to that chapter, I'm going to review it anyway because I'm not sure whether it's going to be on the exam or not. So I'd rather you know it than not. Chances are, if it got removed, I don't imagine it would be there. Okay, now when we think of the slowness, who can be slow? Well, when you have depression, your mood is down. You're not going to be jumping up and down. Also, schizophrenics can have slowness. So you see a lot of that in these patients. So there's a type of schizophrenia back in DSM-4, which was called the catatonic type, right? That was the person that would stay in a fixed position for hours. They wouldn't move. So you're going to see a lot of the slowness as well. Now, there's a side effect of the medications, which is called akathisia. Now, akathisia is nothing more than generalized restlessness. So patients are restless. They're pacing. They're moving back and forth. Oh, my mouse got stuck. They are moving back and forth. Oops, there we go. Sorry, mouse trouble. And it's a side effect of the antipsychotic medication. It's very important that you understand what akathisia is, because it's a side effect of the antipsychotic. So if you think that your patient who has schizophrenia and now has akathisia, and you're seeing it as the restlessness from schizophrenia, what are you most likely to do with meds? Are you going to give them more, or you're going to give them less? If you don't recognize the akathisia, your intention is to give them more. And what you're going to do is make the akathisia worse. So what you have to do with akathisia is that you've got to lower the dose. Or you're going to give them a benzo. Or you're going to give them a beta blocker. Or you just switch them to a drug that tends to do it less. So what kind of question could you get on your exam about akathisia? Well, let's review one. They tell you about a patient who has been placed on drug X. Well, weeks later, the patient tells you that they can't sit still. The patient tells you that he's constantly pacing. Then they're going to ask you, what is the diagnosis? Then you have to recognize that that is, of course, akathisia. Then they want to know what kind of medication could do it. So let's assume they give you haloperidol as a choice, and they give you risperidone as a choice. So what have they done here? They've given you an old one, and they've given you a new one. What do you think would work better? If they give you an old one, right? This is the old one. and they're giving you the new one, what is the better answer? Between the old and the new, which one causes it more? The old one causes it more, exactly. So if these are your choices, you say haloperidol tends to do it more than risperidone. Both can do it, but remember the old does it more than the new. Okay, let's change the answers. What if they make you choose between risperidone and olanzapine? So now what I've done is that I've given you two news. Which one of the news tends to do it the most? Exactly. Risperidone is an antipsychotic that has a side effect profile very similar to Haldol. So it's going to do it more. Not only does it do it more, but it's the one that does it the most. So in this choice, you would pick risperidone as the one that most likely gave the patient the akathisia. Does that make sense to everybody? Okay, a good way to remember it is one thing that we use is that we're going to talk about penes versus dones. Anything with the pene, anything with the done tends to increase movement. Okay? The penes tends to increase weight, tends to cause more cholesterol problems, diabetes problems, etc. So, for example, unfortunately, aripiprazole doesn't fit in this. Olanzapine, quetiapine, all fit in the penes. Cyprasidone, risperidone, all fit in the dones. So risperidone and cyprasidone tend to have a lot of movement side effects. Olanzapine, quetiapine, clozapine tend to have a lot of weight gain, cholesterol, etc. Okay? All right. So let's go back to the slides and let's keep talking. Is anyone out there from Miami? Okay. All right, let's continue. Then we have, let me get my color out here. Now, as far as the attitude towards the examiner, we just want to know, are they cooperative, are they not? So this one is important, this one is important. Yeah. Then we want to know, how is the mood? Mood and affect are not the same thing. Years ago, mood disorders were called affective disorders. They changed that and now they call them mood disorders. Mood is subjective. Mood is how you feel. So it's what the patient is feeling. Today I feel angry. Today I feel sad. Today I feel happy. So you ask the individual, how are you doing today? Ugh, my life sucks. That's describing how they feel. Affect, on the other hand, is that I'm going to look at your face and I'm going to determine your mood, because our moods are always in our faces, right? So typically, the mood and the affect always go together. When the mood and the affect go together, it's a term called congruent. So if the person is smiling and they tell you they're happy, then that's a mood congruent affect. If the person is going and they tell you they're happy, then that would be a mood incongruent affect. So affect usually will get, so it would be incongruent, okay? Incongruent. Affect, typically on the exam, will be, let me go to the whiteboard for a second. When they're describing affect on the exam, they could use the word blunted, or they could use the word flat. Blunted is less than normal. Flat means no emotion whatsoever. When you see these two terms on the exam, What diagnoses do you think I want you to look for? What disorders will give you a blunted affect or a flat affect, meaning a reduction in how we express our emotions? Not depression. They won't use it for depression. I mean, they could, but they tend to use it more for someone else. Schizophrenics, exactly. A schizophrenic will tend to have a blunted or a flat affect. I mean, depressed people will look depressed. They're crying, their face is sad. So when you have no emotion, then that's what we're talking about. Have you done neurology yet? Neuro? Yes, great. So what medical disorder gives you a flat affect? That mask-like face. Parkinson's, exactly. So when patients have Parkinson's, you know, that lack of emotion, that would be a flat affect. So are we okay with affect? So mood and affect, remember, they're different. Okay, then I know you went over neuro already, so speech is something that we listen to as well. How is the person talking? Are they talking fast? Are they talking slow? Are they using words that don't make any sense? Like, for example, schizophrenics have something called neologism, where they make up words. People who have severe thought disorders, they're really difficult to understand. So listening to them is going to be very important. One word that I want you to know about speech is going to be the term pressured speech. When you see pressured speech, what I want you to think of is bipolar disorder. Okay? So bipolar disorder is what I want you to think when you see pressured speech, which is mania. And the moment you have mania, you automatically have bipolar. That's what you got to remember. Mania equals bipolar disorder. Does that make sense to everybody? Okay. Then we're going to look at perceptual disturbances. So what are the perceptual disturbances? Give me a second because they are not here. So let me go to the whiteboard. When we're looking at these disturbances, you've got two main differences that I want you to know. What is the difference between a hallucination and an illusion? Okay? So one of them, what we're going to focus on is whether or not there's a stimuli, okay? The stimuli, the illusion has a stimuli. So what does that mean? If you are in a room by yourself and you hear, then there's no stimuli there. That would be a hallucination. So hallucinations are basically false sensory perceptions. If you're walking down the street and you hear, how many of you have been walking down the street or you're somewhere and you hear something and you turn around because you think someone's called your name? Everyone has had that, right? That's an illusion. How many times have you been watching a scary movie? Let's say you're watching Scream on TV or Freddy Krueger on TV or some slasher film, and all of a sudden you hear a door or you hear something in the house. How many of you think that there's someone in the house? Right. Those are all illusions. So when you think of pathology, which one do you think is sicker? A hallucination or an illusion? Hallucinations are definitely sicker. So let's talk about the different types of hallucinations. We have auditory hallucinations. Auditory hallucinations, what I want you to think of basically are patients who have psychotic disorders. So when you are psychotic, I know that doesn't look like the word psychotic. Oh my God, Freddy Krueger, yikes. I don't know if you see Freddy Krueger. Oh, that's not what I want to see when I come home at night. So when you're schizophrenic, when you have schizophreniform disorder, when you have brief psychotic disorder, when you have schizoaffective disorder, when you have bipolar disorder with psychoses, you're going to hear voices. Then there's another type of hallucination, which are the visual hallucinations. And I don't want you to think of schizophrenia. I want you to think of drugs. People who use drugs will see things. People who stop using drugs will see things as well. For example, people when they're under the influence of cocaine can have visual hallucinations. People who are in alcohol withdrawal will have hallucinations. How many of you have seen a question like this? A patient gets admitted to the hospital. The next day, you go into the patient's room, their hands are shaking, and you see them picking little things up that are not there, or they tell you that there's little bugs or little insects crawling all over the place. How many of you have seen questions like that? We all have, right? I just had a patient on the psych unit a day ago that went into DTs and we had to transfer him out. He had to be put in seclusion because he was so out of control. And as I'm watching him, I'm seeing him on the ground picking things up that aren't there. When I walked in and said, "What are you doing?" He says, "I'm picking up the bugs." And I said, "What bugs?" "The bugs that are there. Don't you see them?" That's what you typically find in patients who are in alcohol withdrawal. Then you have something called tactile hallucinations, where they feel like they have things crawling all over their skin. Now, you're going to see that in two situations on the exam, typically. You might see it in alcohol withdrawal, and you might see it in cocaine intoxication. So these are the two that will give you something called formication. And formication is when you feel you have ants or insects crawling all over your skin. Okay, so alcohol withdrawal and cocaine intoxication. A lot of times people, when they're using stimulants, you'll notice that a lot of them have scabs all over their body. Why do you think they have scabs? Because they pick. They pick because they think they've got things, and that's what's causing it. And the last one that I think is important is olfactory hallucinations. And this is typically seen in seizures. Now you should know which seizures because you already had this. So what seizure disorders gives you these olfactory hallucinations? It's usually temporal lobe or complex partial, and what they smell is something bad. They don't smell apple pie, or they don't smell I don't know what's yummy, like cookies or something. They smell something gross and disgusting. And that's usually like burnt rubber, burnt coffee. And that's what they describe as the aura. Okay? So these are the things that typically appear on the exam. Let's go back to the slides. Okay, let's move on. Then we're going to look at thought. And the way we assess thought are in two ways. We assess form of thought and we assess content of thought. Form of thought is how you think. So we've got something called flight of ideas and we've got loose associations. Both of them are rapid shifting of topics. So I'm going from topic A to topic B to topic C relatively quickly. But what's the difference between one and the other? The flight of idea has a connection. Loose association has no connection whatsoever. So what does that mean? You know, the other day I was watching HSN, and they had these sheets that were in orange. And I thought, that's really a nice color. Look, my cup is orange. I went to UM, and as you can see, he's orange and green. I love green. Green is hope. And I always have a lot of hope about my life. Every once in a while, I think about my life, and I wonder what's going to happen to me in a few years. What did I just say? Is that flight of ideas or loose associations? That's flight of ideas, right? Why? Because something makes me jump from one topic to the other. I went from orange sheets to orange cup to, I forgot what else I said, but obviously there was something there. If you have no connections, you know, I live in St. Pete and I think it's raining. The beach is beautiful. Oh, wow, I love pizzas. Italy is just a wonderful country. My feet hurt. What is that? That would be loose associations, okay? So you're going from one thing to another. Imagine having a conversation with someone like that. You're going, what in the world is this person trying to say? Do you need to know definitively what these definitions are? Just understand that typically this is not a rule. Loose associations, because this is so loose, what kind of disorder do you typically see it in more frequently? Loose association, schizophrenia, whereas flight of ideas more in mania. Then we need to know, what is content of thought? Content of thought is just what's inside your brain. Am I going to hurt myself? Am I going to hurt my neighbor? Do I believe that I'm Jesus Christ? So delusions, paranoia, suicidality, homicidal, those are all contents of thought. Let's talk about delusions. I need to go to the whiteboard. Okay, so what is the definition of a delusion? A delusion is a belief that is fixed, okay? So you believe in something that is, to your eyes, totally true. Now, we see delusions. Let's review about common things for the test. When we're thinking about schizophrenia versus delusional disorder versus mood disorders, right? If you're manic or if you're depressed. Let's go over some of the delusions. Because looking at the content of the delusions can sort of make you think, is it one thing or another? Typically, schizophrenic delusions are bizarre. Okay, they're weird. They don't have to be weird. DSM-4 made the strict criteria that they had to be weird. DSM-5 removed it. So just understand that they're usually not delusions that most people would believe. So if I believe that the government planted a chip in the middle of my brain and that chip is controlling my actions, how many of you believe that that is possible? So that's the type of delusion that you see in the patient that is schizophrenic. A delusional disorder patients are delusions which are believable, right? Meaning possible. Like, I own AT&T, I own Apple, I own things like that. Those are things that you can say to yourself, possible, highly unlikely, because honestly, if I owned Apple Computer, or if I owned Facebook, or if I owned anything like that, what are the chances that on a Friday night I'd be sitting in front of this monitor talking to you? Very little, right? Exactly. I'd be doing who knows what, who knows where. But looking at the content could make you go one way or the other. Here's another little clue for you. Schizophrenics typically do not function. People who have delusional disorder function. Now let's look at delusions and mood disorders. For the exam, now remember, this is not a rule, but for your test, typically, when we think of a manic patient, what kind of delusions do you think they're going to have? They're going to have grandiose delusions, right? I'm the smartest, I'm the brightest, I'm a super genius. Those are the things that you tend to find. When you're depressed, what kind of delusions do you think you're going to have? There's something called nihilistic delusions. Oh, the world is terrible, we're all going to die, the world is coming to an end. So if your mood is down, then what is it that you're going to believe in? Things that are down as well. So understand that these delusions, they can take many different forms. Is everybody okay with this? All right, let's go back to the slides. Okay, let's see where we left off. Then let's do the sensorium and cognition part of the mental status exam. How many of you here have done a little test called the mini mental status exam? Mini mental status exam. How many of you have actually done that test? It's very common, right? It's a nice little test. You take it at the bedside. You could give it in your office. Its score is up to 30. Anything like 23 and below, we're looking at some sort of cognitive deterioration, right? So what do you think you give the test? I mean, I'm sure we could take it too. I hope we score high. So where do you think this section, where do you think the mini mental status exam came from? It came from this section of the mental status exam. So we want to know, is the person alert? What's their level of consciousness? This is important because later tomorrow, when we go over delirium and dementia, you're going to notice that delirium patients tend to have fluctuating levels of alertness as well as fluctuating levels of consciousness, whereas dementia patients tend to be intact. Orientation is something that's very important. We want to assess if they're oriented to time, are they oriented to place, and are they oriented to person. Typically what happens is that when you have patients who have dementia, early on, patients who have dementia have the possibility of getting a clue that they're starting to forget things. How many of you forget names, forget things today? How many of you forget things every once in a while? We all do, right? How many of you have said to yourself, oh, I must be having Alzheimer's disease? How many of you have made that comment? We all have, right? We might have. But if we were to say that when we're now 65, when we're 70, is it as funny as it was 30 years ago? The fact that we're forgetting things. No, it stops being funny. So the patients who have dementia early on have the ability, they don't have to, but they may have the ability to realize that they're forgetting things. So what do you think demented patients do? A lot of them early on, they lie, they confabulate, they make up stories. So when we have a patient who we are assessing orientation, we want to assess, are they oriented to time? What's today's date? What's the month? What's the year? What's the day of the week? What's the season? Place is what city are we in? What state are we in? What county are we in? What building or where are you? What floor are you on? And person, of course, is do you recognize family, friends, etc. When patients are at end-stage dementia, what typically happens to them? Their families come to visit. They don't even know who they are. So typically what happens with patients who have dementia is that they become disoriented in that direction. First comes time, then comes place, then comes person. Does it mean that this is a rule? No. Typically that's the pattern that it follows. Okay? Does that make sense to everybody? All right, so let's move on. Then we assess memory. How do we assess recent memory? We assess remote memory. We also want to assess immediate retention and recall. So how do we assess recent memory? Everybody's favorite question is, what did you have for breakfast? Well, guess what? I'm starting to get dementia, and I don't remember what I had for breakfast, but I know that eggs, toast, and juice are breakfast items. So when you ask me, what did I have for breakfast? I'm going to say to you, well, of course, I had scrambled eggs and toast and orange juice. And you think that my memory is okay, but you never bothered to check. So when you ask the nurse what I had for breakfast, the nurse will say, she didn't eat today. So you always need to make sure that you ask staff to verify these questions. So when we assess memory, let's go to the whiteboard. We're going to assess, let me get something to write on, hold on. 1 second, let's use a different color. We want to assess recent memory. We want to assess remote memory. So you might find out things about their past you could ask them. We want to assess immediate retention, where you say 3 things and you ask them to repeat it. And then you want to assess recall, where you wait 5 minutes and then you ask them to repeat it. So you might say, okay, I'm going to say 3 words and I want you to repeat them. Cat, pencil, train, or whatever it is that you use. And I'm going to give you a friendly advice. Whatever words you use, you write them down, because you don't realize how often we forget our own words that we give to the patients. So then you wait 5 minutes and you ask the patient to repeat these 3 words. Okay? And that's how we assess memory. Then what we need to assess also, let's go back to the slides, is concentration and attention. And this is where we're going to do the serial 7s or the serial 3s. So the serial 7s is that we start with 100 and we ask the patient to subtract from 7. So you're going to do it for 5 trials. So it would be 193, 86, 79, 72. You might do it with 30, ask them to subtract 3. 30, 27, 24, 21, 18, and 15. If the patient is struggling, then pick a word with 5 letters like world, ask them to repeat it backwards, DLROW. Now you're probably wondering, wow, she can really get that. And the only reason I get this is because I've said it so many times, because if not, I would be WORDL, and I'd be struggling just like everybody else. When this is affected, typically patients who have depression tend to have problems with concentration and attention. So it's very normal for patients when they're depressed to say to you, wow, I don't remember a thing. I don't remember where I put my keys. I read things in the paper. I have no idea what I'm reading. That's because their concentration is affected. Then we want to know if they can read and write. So you might give them a sentence. For example, you hand them a piece of paper that the words close your eyes are on it. You give it to them. They have to read it and do it. And you also want them to write a sentence. We also want to assess visuospatial ability, and that is the interlocking pentagrams. Of course, mine is not coming out that beautifully. Let me try it again. There we go. I think this is a little bit better. And then you're supposed to draw that. If you draw it perfectly, you get a 1. We also want to assess abstract thinking. So the way that we assess abstract thinking is that we can either test proverbs, he who laughs laughs best, or he who lives in glass houses should not throw stones, or we assess it with similarities. How are an apple and an orange alike? Well, if you have a concrete thinking, you'll tell me they're both round. If you have abstract thinking, you'll tell me they're pieces of fruit. How are a bird and a plane alike? If you have concrete thinking, you'll tell me that they're both, what did I say? Oh, a bird and a plane. You see what happens? A bird and a plane both have wings. What would be the abstract answer? That they both fly. And then fund of information and knowledge would be a rough estimate of the patient's level of intelligence. Who's the president of the United States? Who was president before him, etc. Who's the mayor of your city? Who's the governor of your state? If I send you to the store with $5 and a loaf of bread is $2.34, how much change do you bring back? These are the rough kind of questions that you can ask patients. Then impulse control is based on observation. So are they sitting there calmly talking to you, or do they get up and punch you in your face? Judgment and insight. Insight is, do you know what's going on with you? And judgment is, Are you able to act appropriately? And the perfect judgment questions usually are, you're walking down the street, you see a stamp, it's got a seal, it's sealed, it's got a stamp, and it's got an address. What do? You put it in the mailbox. You're in a crowded theater, you see smoke coming out of the vents. What do? You get up, you look for the exit signs, and you walk out. Those are the types of questions they'll ask. And reliability is, can the patient accurately assess his situation? So that's it for the, for the mental status exam. So now you don't need to know word for word what it is. As long as you understand general concepts, you're going to do fine in that section. And again, like I said, they're not going to say, what's a hallucination? What's loose associations? But they could use the word pressured speech. They could use the word flight of ideas when describing a patient. Then interviewing techniques is something that came out on step 1. You're going to see it again on step 2, and you're going to see it again on step 3. So typically when we do an interview, we want to start the interview by asking patients questions that are called open-ended questions. These are the questions that you cannot answer in a yes or no. So the patient comes in with chest pain. My first open question should be, tell me about the pain. So the patient would say, well, you know, doc, it started early this morning. I woke up, I got out of bed, and all of a sudden it hit me. I had this pain of my chest. My father died of a heart attack. I became very nervous, so I came to the hospital. Then you have to switch from what's called open-ended to what's called closed-ended, which is the question that allows a yes or a no answer, okay? So now you say, does it hurt when you breathe in or you breathe out? Does it hurt more when you're sitting or when you're standing? Does it hurt more when you're on your side or when you're lying on your back? So you're going from very broad questions, which is an open-ended, to a very narrow question, which is closed-ended. So the closed-ended questions are the ones that can be answered in a yes or no. Another type of thing that we do is a facilitation. And those are cues that we give to our patients that tells them that we're listening. For example, silence is a facilitation. Nodding your head is a facilitation. Saying, continue is a facilitation. So these are either verbal or nonverbal cues that tells the patient we are listening. A confrontation is where we say something about the patient. Typically, whenever we have confrontations, what does that do? It makes us angry. We don't like to be confronted. How many of you, for those of you that are married men, you're going out, and just as you're about to walk out the door, your wife looks at you up and down and says to you, is that what you're going to wear? How many of you have had that experience? I mean, women are infamous to do this. And I think we get it from our mothers, because the daughters, when you go home to visit your mother and you're about to go out the door, that's when your mother looks at you and said, is that what you're going to wear? So I think that's where we get it from, and we pass it on to our husbands and to our children. So we all do that. And how does it make you feel being on the receiving end of that? You're angry, you're upset, so we should never confront patients. However, there are certain situations where confrontation is very good. And what kind of patient am I describing? What do you think? I don't know if you can tell what I drew, but substance abuse, right? You need to confront them. That's a martini glass. A cocktail, right? So you need to tell them, when the patient says to you, I'm not an alcoholic, you have to look at them and say, yeah, you are. You're a crackhead, you're a dope head, you're a coke fiend, you are an alcoholic, accept it. So they're the ones that need that in their face. Reassurance is something that we tell the patient. If they believe it, adherence goes up. If they don't believe it, then adherence goes down. And a leading question is one that you should probably try to avoid because the answer is in the question. Is the pain in your chest a crushing pain? Are the voices telling you to kill yourself? That's a leading question. You want the patient to tell you what the voices are saying. So when the patient says to you, I'm hearing voices, the next question would be, tell me about them. The patient will then say, I'm hearing voices, and when we say describe them, they'll have to say it's a male voice, a female voice, etc. We don't want to put words in the patient's mouth, and that's what leading questions tend to do. And I think that's it. Any questions on this chapter? All right, so let's take a 10-minute break, and I'll see you in 10.